Dan, thank you very much for the beginning, and I'm going to challenge ourselves a little bit and take us to a talk that was earlier this day. Maya, I don't see you here. Are you hiding somewhere? But I don't know where is Maya, but Maya talked to us today about cardiomems, and she talked to us about remote monitoring and pressure. And as someone that also trained here in New York, and a center like Dan and Sean, we are very hemodynamic centric. And the question that when we came across this technology was, how can we reconcile the differences between hemodynamic and volume? Are they equal? Are they different? Are we comparing oranges and apples? And in order to do so, we really say, wow, there is now an ability to assess the volume in the lung. But is the volume in the lung and the pressure in the lung say the same? Because we just heard from Maya, as we discussed, that there is a 30% reduction in readmission if we address pressure. But volume comes before pressure. And if we look at the animal model, we understand that we need to build up volume in order to get pressure. So the question that we ask is, what is the relationship between ReDS that give us the volume and the pulmonary capillary wedge pressure that we all know how to treat and we all believe in and we all understand what it is? In order to do so, we took a cohort of patients that have heart failure, 139 patients. And anyhow, those patients were assigned to go and get a right heart cath in our cath lab. And during this right heart cath, they will get a CVP, right ventricular pressure, PA pressure, pulmonary capillary wedge pressure, and cardiac output. At the same time exactly, they are going to get a ReDS reading. And we're going to see how they correlate with each other and what can we learn between the volume-pressure relationship among those patients. So those were the patient population. It was 55-year-old group of patients. BMI was 28. In the Midwest, we are a little bit heavier than you guys in New York. 72% were male, and Caucasian was 57%. The LVEDD was 5.3. As you can understand, it's a mixed group of patients between HFpEF and HFrEF, and the average EF is 45%. The rest is a classical heart failure population. Diabetes mellitus 36%, AFib 27%, history of ventricular tachyarrhythmia 25%, and COPD in 6% of the patient. Let's first understand the distribution of the ReDS and the distribution of the pulmonary capillary wedge pressure among those patient population. The ReDS is on the left. As you can see, most of the patients drop in the range of what Dan just told us, 35. But it range all the way from 15, that's supposed to be very, very dry lung, all the way to 60, meaning someone that is probably in full-blown pulmonary edema and his lung is soaking with fluid. Very similar to that, they look very similar. We see the wedge range from single-digit wedge all the way to a wedge of 40, probably correlate with each other. So now, let's see what happened when we put them one on top of the other. And this is actually very important. We did not expect to see a direct correlation between the two values. We understand that volume builds pressure, and as such, we just want to know when can we need to act. So let me guide you through those four quadrants that we can see here. The first quadrant is a quadrant in which the pulmonary capillary wedge pressure is low and the ReDS is low. You can see we have a lot of patients like that, and it seems to be in agreement with each other. The second quadrant that I wanted to see is the quadrant in which the pulmonary capillary wedge pressure is high and the ReDS is high. Again, those are the patients that we think are in pulmonary edema based on wedge, and we can definitely see it. We rarely see patients, really rarely see patients in which the wedge is high and the pressure is low. The pressure is high and the ReDS is low. And we can see some patients in which the ReDS is high, but the pressure is still not high enough. So if we're trying to understand what does it mean, we will do what we call a ROC curve. And in this ROC curve, we are going to understand the sensitivities, specificity to detect a specific parameter. We choose a parameter of pulmonary capillary wedge pressure of above 18, in which we think that this will represent a patient that will be congestion by hemodynamic parameters. As you can see here, we have an AOC curve of 0.85. This is actually a very good AOC curve to detect those kind of patients. What gives us a sensitivity of 90%, a specificity of 77%, but more important, a negative predictive value of 95%. So this is going to the thing that Dan just mentioned. This is a point of care. You have a patient, is coming to you with shortness of breath. You want to assess whether or not this patient is congestion. And if you assume that the wedge above 18 will represent congestion, you can put a vest on him. By putting a vest on him, if the value is below 35, you in 95% of the cases will be right and say, we don't have elevated wedge pressure here. If the value is positive, we definitely need to continue and explore and to detect whether or not this patient is congestion. But as a point of care and triaging our patient and detect patients that are not congested, we can successfully do it in 95% of the cases. So let's understand how is it reflected in other parameters. And let's understand the ReDS, the wedge, and the CVP all together. This is something that Dan and I did, I think 5 years ago already, a correlation between the CVP and the wedge. And we really believe that when we think about hemodynamic of heart failure patient, we want to see our patient somewhere here, with a CVP below 12, with a wedge below 18. But we know that we have 4 different groups. We have patients that the CVP will be high, the wedge will be low, there will be RV failure patient. We have patients that the wedge will be high, the CVP will be low, there will be left ventricular patient. And we have patients that have biventricular elevated filling pressure. Look what happened when we look at the ReDS of those 4 quadrants. The group that we can recognize are the groups that belong to 3 and 4. Elevated wedge without elevated CVP, or elevated wedge and elevated CVP. Definitely dramatic increase in the ReDS read compared to patients that the congestion is only on the right side. So to conclude, lung fluid content as measured by ReDS correlated very well with pulmonary capillary wedge pressure. The high sensitivity and specificity, and especially the negative predictive value, makes ReDS a reliable non-invasive tool at the point of care to rule out elevated wedge in heart failure patient and to help heart failure patient medical management. I want to emphasize one thing. We compare everything to hemodynamic because that's the way we train, that's the way we think. But actually, maybe we need to intervene earlier when only the volume is going up, before actually we see increase in the pressure. So thank you very much, and I'm going to continue with Sean.